Good afternoon, everyone. This is our Lynn Cancer Institute updates for 2026 from our Survivorship series. Both of our speakers today are from our Drummond Therapy Centers. Today's topic will be rehab after head and neck cancer. And we'll be learning from two amazing speakers, Anita Parando, oncology rehab and lymphedema therapist, and Caitlin Teston, speech language pathologist. At the Lynn Cancer Institute, we believe that education and awareness, a variety of treatment options, the expertise of our staff, and as we're seeing today, the benefit of our multimodality method of treatment, all combined will truly make a difference in the lives of our cancer patients. In the interest of time, both Anita and Caitlin's bios were sent to you by email. During their presentation, we ask you to please take notes. And as you have a question, please put it in the chat box or in the Q&A. And there will be time at the end of their combined presentation for them to respond to your questions. So that being said, we're very proud to welcome you to the Lynn Cancer Institute and the Drummond Therapy Centers, and to introduce our first speaker, Anita Parando. Anita?
Thank you, Jen, and good afternoon, everyone. We're going to start with an overview of head and neck cancer. We're going to identify the issues that compromise function and quality of life in head and neck cancer survivors. And we're going to describe the physical therapy interventions to help address these impairments. We're going to talk briefly about advancements in radiation therapy with the proton beam radiation, the importance of embedding rehabilitation within the patient's medical treatment, and lymphedema as a special consideration. Head and neck cancer includes malignancies of the oral cavity, pharynx, larynx, sinuses, and salivary glands. Common treatments include surgery, also called neck dissection, radiation therapy, chemotherapy, or a combination of the above. And there is a high risk for functional impairments in this patient population due to the location and treatment side effects. And I really like this picture because it shows how much is going on in the neck. The muscles, nerves, blood vessels are all contained in a very small space. And this image doesn't even include the structures of your airway and speech and swallow that my colleague Caitlin will be talking about in depth in a little bit. So the medical team gives much consideration when they're developing a treatment plan to preserve these important structures and function. There are very predictable impairments that can occur during and or after the treatment of head and neck cancer. The goal of rehabilitation is to prevent or minimize impairments through early intervention. The earlier the better, ideally concurrent with medical treatment. And why is this? Well, first of all, this is, excuse me one second. First of all, this is the best practice. In healthcare, in medicine, in anything, we know that an ounce of prevention is worth a pound of cure. So this is our best practice. But I also want to talk a minute about financial considerations. So as we know, cancer care is very expensive. We're seeing patients with $3,000, $4,000, $5,000, $6,000 annual deductibles. If we're able to embed rehabilitation within the patient's medical treatment and see patients at certain key points, pre-surgery, post-surgery, pre-radiation, post-radiation, we're actually able to identify impairments in their earliest stages, or even identify the potential for impairments, and we're able to prevent. And this is much better for the patient rather than waiting for an impairment to develop and establish itself and be identified. Well, that can result in weeks and even months of therapy. And that creates a financial, emotional, and time burden for patients. So the earlier we can get them in, the better. So some possible impairments after neck dissection surgery. Patients may have shoulder and neck stiffness, which is tightness or reduced movement in the neck and shoulder. As shoulder or neck may feel weaker or tire more easily due to nerve involvement. Swelling in the neck and face may occur, especially if lymph nodes were removed during the surgery. Lymphedema is a very common side effect in head and neck cancer treatment. There might be areas of numbness, burning, tingling about the neck, ear, or surgical incision, and the surgical scar may feel tight as it heals. It is more pronounced with radiation therapy, but we do techniques to help with that. And some movements, like reaching overhead, may feel harder at first, but the good news is that most of these effects can be prevented, resolved, or improved with the guidance of a physical therapist and, of course, time. So radiation therapy. Radiation therapy damages the DNA of cancer cells so that they can't reproduce. They're either traditional radiation, which uses photons, which is light energy, or protons, which is a newer technology. It's used alone or combined with chemotherapy and or surgery. Now, radiation damages the DNA of the cancer cells, but it also damages the DNA of every structure that it touches or that are in the radiation field. Now, all of these treatments, radiation, surgery, chemotherapy, are very effective life-saving treatments, but of course they come with side effects. And it is our job as a medical team to try to mitigate those side effects. So some of the structures that could be in the radiation field that we see are connective tissue, muscles, vascular structures, lymphatic structures, nerves, and skin. So early effects of radiation therapy, which can happen during radiation or days to weeks after, are typically redness and a burning. Late effects, which can occur months to many years later, there are many late effects. Some of them include fibrosis, stiffness, decreased joint mobility, and lymphedema. So radiation fibrosis risk factors include dosage. The higher dosage, the higher the risk. Time from radiation. Radiation fibrosis actually really begins after radiation is completed. It's not something that happens immediately. Again, it's something that can happen weeks to months later. The tissue type, neural tissue, skin, lymphatic tissue, tend to be more sensitive to radiation. Prior radiation. If you're radiating on top of tissue that has been radiated before, that can cause some problems. And local surgery, of course, if you're combining surgery and radiation, you are at higher risk for fibrosis. So again, radiation fibrosis, common side effect of radiation therapy. The treated tissues become tight, stiff, or less flexible, and it is caused by scar-like changes in the skin, muscles, and other soft tissues. Again, can develop months or even years after treatment. Radiation fibrosis syndrome is a broader term, and it refers to a group of long-term effects caused by radiation. So at this point, there are multiple structures involved. They include the muscles, blood and lymphatic vessels, nerves, and other structures. Possible radiation fibrosis impairments include cervicalgia, which is neck pain, impaired neck range of motion, so patients may have a difficult time moving their neck, dropped head syndrome, shoulder dysfunction, having trouble raising their arms, head and neck lymphedema, trismus, which is trouble opening the mouth, or dysphagia and dysarthria, which is trouble swallowing and trouble speaking. Physical therapy helps with radiation fibrosis by helping to keep the body moving, flexible, and comfortable. So we may do stretches and movement, so exercises to help prevent the neck and shoulders from getting too stiff. We use specific soft tissue techniques to help loosen tight and stiff areas and keep tissue mobile. We use special techniques to help the scar tissue, to help keep it more flexible and less restrictive. We may do postural training to help patients help sit and stand in ways that reduce strain and tightness. We may do strengthening exercises to build the muscle to support better movement and reduce fatigue. And of course, the most important thing is education and a home exercise plan. We work with patients to develop daily exercises and an exercise routine to maintain their progress over the long term. Proton beam radiation therapy. As part of this series for Head and Neck Cancer Month, which is this month, April, Dr. Ross Taylor will be speaking next week at this time. He's going to get into a lot more detail about the various radiation technologies, but I just wanted to touch on the proton beam radiation therapy because it is an exciting advancement specifically in the treatment of head and neck cancer. So rather than using photons, which is light, proton beams use positively charged protons to damage the cancer DNA cells. The protons are taken from hydrogen atoms, sped up to nearly the speed of light, which gives them enough energy to travel into the body. Magnets are then used to paint the protons onto the exact shape of the tumor. As the protons travel through the body, they release a small amount of energy on the way in, but they release most of their energy, their payload, at a very specific point, then stop. The components of the machine are the accelerator, and this is where the protons are generated and accelerated to nearly 60 times the speed of light. The gantry, which is a massive rotating structure that circles the patient 360 degrees to deliver the beam from any angle. This machine is so large, a building had to be built to house this machine. So there's a beam transport system, which is a series of powerful bending and focusing magnets that guide the protons from the accelerator to the nozzle. And the nozzle is the final delivery component containing scanning magnets that map the beam to the exact shape of the tumor. And this is just a nice little graphic comparing conventional photon radiation, where you see there's an entrance and an exit dose, and proton, where the payload is pretty much left where the tumor is. Advantages of proton beam radiation. A 2025 study showed that survival among the proton group was 91% at 5 years compared to 81% for patients treated with traditional radiation, and this is a statistically significant difference. In addition, patients treated with proton were less prone to experiencing swallowing difficulties, reliance on feeding tubes, dry mouth, and severe lymphopenia when compared to those undergoing conventional radiation therapy. So now moving on to immunotherapy. Immunotherapy uses the immune system to fight cancer. So it blocks proteins that stop the immune system from identifying cancer cells and attacking and killing them. Key advantages include combining immunotherapies with targeted agents, and these advancements are rapidly shifting the focus towards a more personalized, less toxic, and effective treatment regimen to improve both survival rates and quality of life. Immunotherapy has become a game changer for head and neck cancer, as well as other cancers that have traditionally been difficult to treat and that don't have many treatment options. Immunotherapy is usually very well tolerated, but it's important for patients to listen to their bodies and speak to their medical team about any changes. Some side effects can include fatigue, digestive and hormonal changes, nerve problems, so numbness, tingling, and that sort of thing, joint inflammation, joint pain, and tendon inflammation and pain, and skin toxicity such as rash. So moving on to lymphedema. Our lymphatic system, along with our venous system, is responsible for moving fluid out of tissues and into the bloodstream. When the lymphatic vessels are damaged by either surgery, radiation, or both, their function is compromised, and a type of edema, which is the medical term for swelling, called lymphedema occurs. It is often undiagnosed and neglected. Lymphedema can be external, which is the face, neck, and chest, or internal, affecting the larynx, pharynx, and oral cavity. And I just want to talk about internal lymphedema for a moment, because with head and neck cancer patients, this is a very particular issue. So, for example, with breast cancer, if a woman develops swelling in her arm, it's purely external. Okay, it's the swelling is happening under the skin. In the case of head and neck, because there are tubes inside the head and neck, you can develop lymphedema in there as well. And as we saw in that photo, in that drawing that I presented early on, all of these structures are very, very close together. So any extra swelling in this area can cause difficulties with speech, swallowing, and respiration. In addition, lymphedema untreated moves into a fibrotic state. So lymphedema over time, if untreated, gets the fluid gets firm and it gets what's called fibrotic. So if patients have lymphedema, for example, they had some lymph nodes removed in surgery, and now you're adding a layer of radiation therapy on top of that, which can cause fibrosis. Um, that is kind of a double whammy for the system, and can cause problems, significant problems in the long run. So as therapists, we like to address internal lymphedema and lymphedema in general aggressively. Lymphedema has adverse cosmetic and physiological and physical consequences, such as infection, breathing, and swallowing difficulties. External lymphedema is diagnosed clinically. Again, that's the lymphedema you can see. It's often under the chin and around the neck. Internal lymphedema is diagnosed by endoscope evaluation and CAT scan. However, up to 90% of head and neck cancer survivors develop lymphedema. And if you look at these percentages are very, very high. I've seen studies that show 97% of head and neck cancer patients develop lymphedema. So as a oncology rehabilitation therapist, I just assume that all head and neck cancer patients have it. The primary goal of treatment for lymphedema is prevention or minimization of lymphedema through early intervention and patient education. If caught in its earliest stages, lymphedema can be reversible. It is a misconception that lymphedema is chronic and progressive. If caught early, the lymphatic system does regenerate and it can be reversible. And our goal when treating lymphedema is not only to move the fluid out of those areas and especially out of those internal structures, but it's also to train the lymphatic system as to how we want it to regenerate and where we want it to put the fluid. And some of the components of complete decongestive therapy include manual lymphatic drainage, compression, exercises, and skincare. Effects of untreated lymphedema, there are physical complications, again, progressive swelling and fibrosis. The fluid buildup becomes more permanent over time, leading to a hardening of the tissues of the face, neck, and throat. That's the internal lymphedema. Skin changes and infections, increased likelihood of infections such as cellulitis, and airway compromise. Swelling in the neck and throat can narrow the airway, and make breathing difficult. In addition, there are early or late functional impairments, difficulty swallowing, speech problems, so swelling of the tongue, lips, or throat can affect articulation and voice quality. Reduced neck mobility, fibrosis, and swelling can limit range of motion, causing stiffness and pain. And a worsening of treatment side effects. If lymphedema develops while the patient is in active treatment, it can actually amplify some of the side effects of that treatment, such as pain, tightness, and fatigue. Now, I really like this slide. It is a great visualization of the evolution of impairment burden in head and neck cancer. So, this timeline is in months, okay? So what we see in month 0 is the diagnosis. Roughly month 1, you'll have the surgery. Typically, patients have chemotherapy and radiation at the same time, so that's roughly months 3 and 4. And you can see at that time, we start to see patients having a high risk for any of these impairments, okay? But you'll notice in this timeline, this risk extends to 11 months after active treatment is completed. So we educate patients on what to do to identify if an impairment is starting so that we can get it in its early stages. And we really monitor well after the treatment is completed for these impairments. But then if you look at this timeline up here in the surveillance and survivorship, now we're looking at 2 years, 3 years. At about 5 years, it looks like the radiation late effects start to come up again. We don't know why. We think that's multifactorial. The research about late effects of radiation is very new, so we don't know all of the reasons. We think it has to do with age, the nature of radiation, comorbidities, and that sort of thing. But as you can see, this is surveillance for impairments related to radiation therapy and cancer treatment for the head and neck population. The surveillance, it's a lifetime surveillance. And it is our job as rehabilitation therapists to partner with patients to make sure they have the tools that they need to manage their impairments and remain in optimal health um, for their lifetime. So in conclusion, patients with head and neck cancer can develop significant impairments. These impairments can, over time, impact patients' quality of life into survivorship. Many impairments are preventable or minimizable with early intervention of rehabilitation, preferably concurrent with and embedded into medical treatment. And patients should not assume that any impairment is normal and should report difficulties to their medical team. So I'm an amateur nature photographer, more of the ocean than anything else. And this was caught with my iPhone, and I was lucky enough to have a monarch caterpillar form a chrysalis onto my patio. And I was there when it eclosed, or when he eclosed. We know it's a male because he has this spot here, and this is for pheromones to attract females. And I brought him over to a plant, and he took a few hours to let his wings dry and let his wings get stronger and have a little snack. And then he, a few hours later, he flew away, I'm guessing to the north with all of the others. So I thought you might enjoy that.
Thank you, Anita.
Thank you for your time.
Thank you, Anita. That was very informative. Caitlin?
Yes. Hi, how are you today? All right, so I'm going to get this up in presentation mode. Hi, my name is Caitlin. I am a speech language pathologist over at Gloria Drummond Rehab in Boca Raton. So the first thing I wanted to address is The question that I get very often, which is, why do I need speech therapy? My speech is fine. Our title is a little misleading. We actually treat more than just your speech. So we actually treat your voice in addition to your speech. We treat language, cognition, and swallowing. Swallowing is kind of the main feature here, where we're going to be talking a lot about because of the effects of radiation on patients who have head and neck cancer. All right. Okay, so as Anita mentioned before, with head and neck cancers, they can occur in the nasal cavity, in the oral cavity or the mouth, the pharynx or the throat, the larynx, which is commonly called the voice box, and then in the salivary glands. So let's kind of talk about what the swallow is. So we do this hundreds upon hundreds of times a day, and we never think about it until something goes wrong. So when we begin to swallow, the first thing is the oral phase. You have to chew your food. That food mixes with saliva to make it easy and soft to swallow. Your tongue pushes it to the back of the mouth. And then at that point goes to the pharyngeal phase, where the back of the tongue squeezes against the back of your throat, where the swallow is triggered. A flap of cartilage called the epiglottis covers and protects your airway as the food and or liquid moves past it. And then at that point, the upper esophageal sphincter relaxes to allow food or liquid to go through it and then head down towards the esophagus, where, of course, it's then transported to the stomach. So here's a little picture just to kind of show you. It is such a complicated, complex task that involves over 20 muscles. Again, we do it all day, every day, but we never think about the intricacies of it. So, and as you can see, if you know, kind of look towards where the neck is, the airway sits in the front and the esophagus or the food tube is what sits in the back. And especially if you're having radiation in this area, it can greatly impact the muscles of swallowing, because the swallowing, during the swallow, your airway lifts and pulls forward. All of those muscles are key. So those are the muscles that can be damaged during radiation. So as far as speech therapy and speech therapists are involved, we love to set up pre-radiation consults, which ideally occur about a week or two prior to beginning the radiation. This allows kind of the ability for us to give you education on what our role is throughout the continuum of the radiation treatment. So we talk to you about your swallow function, kind of like I just did. We'll discuss what a modified barium swallow study is, which is where we use an X-ray machine and take a video of you while you're eating and drinking things with barium to assess your swallow function. We talk about signs and symptoms of aspiration, which is when food or liquid wind up going down into your airway. We discuss possible side effects of radiation and tips to manage those side effects. Just to kind of touch base, a modified barium swallow study wouldn't be conducted until after the radiation, but we just give you all the education before, just to give you a heads up on how everything is going to work. Other things that we discuss in the pre-radiation consult include showing you the swallowing exercises that we want you to complete throughout the continuum of not just when you're doing the radiation, but also after radiation, and ideally for the rest of your life. As Anita mentioned, radiation fibrosis continues to occur over time and can damage your swallowing. So, we have patients who their swallowing recovers immediately after the radiation, within that 12-month window that Anita showed the infographic of. And then say from, year 1 to year 3 to 5, swallowing is fine and there's no issue. And then all of a sudden later on down the line, the fibrosis can set in the neck muscles and all the swallowing muscles, and we wind up with a swallowing issue at that point. So that's why it's crucial to do these swallowing exercises and make sure that you're adhering to them to prevent that, or at least delay that from happening for as long as possible. Yeah, we discussed the future changes to your swallows even years after radiation has finished. So then the meat and potatoes of when speech therapy happens is actually after radiation treatment. We typically prefer to start about 4 weeks after your final radiation session. That's because a lot of swelling, irritation, swallowing pain is occurring. Obviously, we can start earlier if necessary, but we like to let things calm down a little bit. And we'll have you come into our clinic. You'll sit down with us, eat a little, drink a little, see where your swallow function is at. If we think it's pertinent, we will refer you to get a prescription from your doctor for a modified barium swallow study to more objectively look at the swallow and actually see inside the musculature to see if you're aspirating on liquids or solids. And then we would have you come in for those swallow strengthening exercises, making sure that you're doing them correctly, modifying your diet, safe swallow strategies, making sure that you're swallowing in the safest way possible. Sometimes patients who have head and neck cancer are prophylactically put on a feeding tube, meaning that the feeding tube is actually placed before the radiation even begins. And that's due to, unfortunately, during radiation, swallowing can become so painful that patients often will stop swallowing. Also, appetite is affected too, and that's another big piece of the puzzle. So we will have patients who come to us who may not have been eating anything by mouth and solely relying on the feeding tube for their hydration, their food, nutrition, and their medication. And unfortunately, during that time period of only relying on food through the tube, your swallow muscles actually atrophy. Just like, if you were to sit in a wheelchair for weeks upon weeks at a time, the muscles in your legs will atrophy. The same, unfortunately, happens to the swallow muscles. So that's where we come in. We can help to rebuild the strength in your swallow muscles, help you to get back to an oral diet or a diet where you're eating and drinking by mouth. Oftentimes, nutritionists are also involved to make sure that you're receiving enough calories so that you're not losing too much weight even after radiation and chemotherapy have finished. Something else that we like to emphasize the importance of is good oral hygiene. Seems like something that's obvious to all of us, but brushing our teeth twice a day, that includes your tongue and your gums, any little crack or crevice in the mouth, flossing. Is extremely important because the cleaner that you keep your mouth, obviously, the better it is for your heart health and your overall health. But if, God forbid, you aspirate, you get something into your airway. If you have bacteria in your mouth because you're not keeping good enough, brushing your teeth enough, and there's bacteria buildup, that can potentially get into your airway, into the lungs, and that's what can potentially develop into pneumonia, which again, can lead to hospitalization, which we do not want, of course. And then, of course, we emphasize the importance of lifelong adherence to the exercises. Anita kind of already discussed this a lot, which was super thorough and really informational for me as well. But discussing the radiation fibrosis, the scarring of the tissues that can make them feel stiff. So if you touch your neck, you can feel how pliable, how soft this is. Unfortunately, down the line, when radiation fibrosis sets in, the neck becomes hard, and those muscles can't stretch like they used to. They can't move. They lose range of motion. Spasming can happen in the muscles, pain, stiffness. Nerves can be damaged or pinched by scar tissue. As she mentioned, lymphedema, swelling, of course. Also, oral issues, including cavities and tooth decay, can also occur. Changes in saliva production, like dry mouth, thickened saliva or mucus, which can be really troublesome for my patients. Trismus, the contraction of the muscles that open and close the jaw. And if there's anything that I can impress upon somebody who's about to begin a journey with radiation due to head and neck cancer, it's that eating and swallowing exercises during and after treatment is crucial. They help maintain the muscle strength, the range of motion, and adherence to the exercises not only strengthens the muscles, but it also helps to prevent delay swallowing disorders down the line. Thank you very much for having me. Here's my contact information. Feel free to reach out to me if you have any questions. I'd be happy to discuss anything with you.
Thank you, Caitlin. I don't know, that was very, both of you, very thorough information. Does anyone have questions? If you do, please put it in the chat box or in the Q&A. Thank you so much, both Anita and Caitlin. This was very, very informative and information and education that many of us are not aware of. So you really explained it so thoroughly and so easily for us to understand. For everyone that's on this presentation, the lecture has been recorded. So if you'd like to review it, look at it again. If you have family or friends or patients that you feel would benefit from this education, please let us know. And in a couple of days, the link will be available so that you can access this lecture again. Lee will be sending out a evaluation form. We really appreciate everyone that can fill out this form. It helps us. It looks like there might be a question here. Let's see. I'll read it and then are there post-radiation treatment options for problems with saliva production and diminished altered taste? Would that be for Caitlin?
I think maybe, Anita, do you have any suggestions?
Okay.
No, I think that might be your world, Caitlin.
Yeah, I saw you nodding. I didn't know if you wanted to jump in.
No,
Yes.
no, no. I was
Oh,
agreeing. I hear the same thing from patients. All that seems to be a very common problem. So yeah, I was nodding
yeah.
to that. I hear that a lot.
So unfortunately for the taste aspect, that is one of the most common things other than the pain with swallowing that we hear. Unfortunately, that's just a timing issue and just, unfortunately waiting it out. But as far as the dry mouth goes, there are quite a few options. That's one of the resources that we provide when you come in, but there are a lot of products on the market that can help. I always encourage my patients to try different ones. I feel like it's like spaghetti, throwing spaghetti at a wall. You got to try which one to, whichever one sticks. There's things like Biotine, but even within Biotine, there's a spray, there's a mouthwash, there's a tablet, there's different versions. There's a product called Xylomelt, which is available on Amazon, which is a patch that actually sticks to the gum, especially overnight. Some of my patients will complain that they'll wake up because their mouths are so dry and they feel like they're choking and they have to go chug a glass of water. Xylomelt helps because it actually stimulates saliva throughout the night, so it prevents that waking up in the middle of the night from the dry mouth. But there are some other holistic things to try, like baking soda rinses. But yeah, there are a number of things that you can try to help stimulate some saliva or help with that. Keeping really well hydrated helps as well. Drinking lots of water, humidifiers, steam, things like that.
There's another question, Caitlin. What should someone do if they develop problems swallowing later on post-treatment?
Get to your doctor ASAP for a referral for speech therapy. That's when we come in to hopefully you've been doing some of the exercises, but if not, we'll introduce you to the exercises. We'll get you to a modified barium swallow study. Like I mentioned with the x-ray video, we'll assess the muscles of swallowing to see exactly where the impairment lies, to see if, God forbid, if you're aspirating on food or liquid, and then we can further target therapy to exactly, where the disorder is.
You. And also in the chat box for Anita and Caitlin, you're getting a lot of kudos. So
Oh, thank you.
a lot of great job, great information. Thank you. Great presentation. Oh, wait a minute. Did we get another one? Just see. No, just those two questions so far. But also to anyone, if you think of a question later, you can add it to the evaluation form and we will pass it on to Anita and Caitlin and make sure that they get the question and are able to respond to you. So thank you both so much. Anita's a pro, and I don't think anyone would realize that this was Caitlin's first presentation. So great job.
Thank you very much.
And
Thank you so much.
thank you. And we know how much goes into this, all the preparation and everything. So we really appreciate this education. We appreciate everyone who's joined us today. And we have kind of a full week this week. Tomorrow, April 16th, our support services department, Elsa Rayner, our LCSW, and Ann Williams Nicholas, also LCSW at Lynn Cancer Institute, will be providing the lecture, The Power of Advanced Care Planning. It will also be at 12 noon. And on Friday, April 17th, as Anita mentioned, our physician panel series will be presented by Dr. Micah Glon, surgical oncology, Dr. Ross Taylor, radiation oncology, and Dr. Matthew Matten, medical oncology. Their topic will be understanding head and neck cancers from diagnosis to treatment. So very great education for our patients and all of those people who are watching who care for our patients. So thank you, Anita. Thank you, Caitlin. And thank you, everyone, for joining us.
You're welcome.
There's one more question. Are barium swallows and speech therapy usually covered under insurance?
If we're talking about Medicare, yes. Most insurances do cover. There might be a copay of some sort. But yeah, definitely you can always reach out to your insurance if you have a private insurance, but Medicare does. And just to clarify, I see the question says barium swallow. There are actually two very different tests. One is called the modified barium swallow. That's the test that speech language pathologists perform for the swallowing up here. A barium swallow actually looks at your esophagus and it's just a picture. So the modified barium is the one I've been talking about during the presentation. It's a video x-ray to assess the muscles of swallowing. Barium swallow is just the esophagus. Just a little aside, because they often get confused considering the names are very, very similar, but they test two different things. But yes, especially Medicare, they do cover it. Maybe a copay is involved, but it's covered. And speech therapy.
Okay, good job. Thank you, everyone.